Hi, everybody. This is Pam Gibson at James Madison University, and I want to talk to you today about the second half of my study of mental health providers seeing people who have sensitivities. So I'm going to share you my screen. All right. Okay. So we asked people if they would be willing to share their psychological evaluations with us, and we looked at them and did an analysis. I was helped in this by Sharon Lockerbie and Jenna Bryant, and we delivered a paper at the Southwest Conference on Disability in Albuquerque, New Mexico in 2009. So our method was that we looked at themes and mental health labels used by mental health providers to describe people with environmental sensitivities. We advertised the study on our website and told support groups about it. And we ended up with 6 women and 2 men who submitted their psych evals. They had a mean age of 56.3 years. All were Caucasian with varying employment status, one with in-home employment, one with in-home and out-of-home employment, and 5 not employed. We were interested in how psychological providers would conceptualize and construct the mental health of people with chemical sensitivity, and some also had electrical sensitivity. So I'm going to talk individually about 7 of those folks, but overall results, 4 of the mental health providers gave the client a purely psychological diagnosis. 2 saw the problem as a mixture of both psychological and physiological matters. 2 of the 8 psychological providers acknowledged their patients had multiple chemical sensitivity, and 1 of these diagnosed depression as a result of the MCS. The psychological labels conferred included somatization, delusional disorder, conversion disorder, mixed personality disorder, depression, and anxiety. In most cases, including those with previous diagnoses of MCS, the chemical intolerance was downplayed and clients received psychological as opposed to physiological diagnoses. So a little more on the results. 3 of the 8 diagnoses were categorized as problems of somatization, a disorder in which people experience physical symptoms or complaints for which medicine can find no organic basis. In these cases, somatization classification was due either to the client's past diagnoses, quote, she has been considered to have possible somatization tendencies in the past, or the client's acknowledged physiological symptoms consistent with anxiety, quote, points toward a somatization of emotional distress, or believed conversion reaction from cognitive and emotional disturbances as a result of MCS reactions, quote, a profound conversion reaction. So somatization has its roots in Freudian psychology. Freud postulated that some people possessed what he called somatic compliance, or the ability to manifest their psychological conflicts in their bodies, rather than to become a regular anxiety neurotic. So we're still leaning on Freud. Okay, so I wanted to talk about some of these individual diagnoses because they are just so fascinating. Patient A, a man, made ill by paint in his workplace. He had career problems, low job satisfaction, stressed occupational relations, anxiety, and acute burnout. He saw a psychologist because he was forced to by his employer. The testing that they used for him was the burnout inventory, the quality of life questionnaire, and the personality inventory. The final evaluative decision of the psychologist was that the psychologist believed he was truly a victim of poison. Yet he lacked the emotional intelligence to deal with it, and that resulted in physical distress or somatoform disorder. Our summary, the examiner concludes that there was an interaction between environmental poisoning and his subconscious avoidance of distressing emotion. The provider believes the patient was poisoned, but that his own somatoform tendencies have made it worse. Okay, So patient B, a woman, made ill by exposures in the workplace, experiencing anxiety, depression, feelings of uncertainty for the future, saw a psychologist because she was referred to a neuropsychologist after exposure to toxic chemicals in the workplace. The psychologist accepted the environmental component, but saw the client as having difficulties coping with the exposures. Psychologists believed the client to have an irregular emotional equilibrium and poor defense mechanisms to contain anxiety and depression due to her sensitivities. Our summary: the examiner believes the patient has been poisoned, but should have been able to deal with it better. Patient C, a woman, exposed to pesticide in the workplace, is often physically ill, has situational depression, neurological injury, irritable bowel syndrome, malnutrition, myofascial pain syndrome, mercury toxicity, unemployment, unable to receive proper medical treatment, and emotionally distressed. Seeing a psychologist because she personally sought therapy for depression and anxiety related to her physical condition. She was tested by an independent medical examiner, IME, and what happened was the administrative law judge, ALJ, agreed with the IME's report of, quote, an extreme, severe, and pervasive somatization disorder, and concluded that she had a very significant functional contribution to her physiological complaints or a profound conversion reaction. Our summary: although the patient's previous primary provider and counselor said she was disabled due to MCS, the ALJ chose to believe the opposite, that she was instead suffering from somatoform disorder. Patient D is a woman who is exposed to perfume, fragrance in the workplace. Her problem is that she cannot maintain employment. She was seeing a psychologist because she was referred by vocational rehabilitation. She was reluctant to take the MMPI. Can't imagine why, given that the MMPI makes the assumption right off that you do have mental problems. If they think you're a normal person, they give you the CPI, or the California Personality Inventory. So her reluctance to take that was viewed as paranoia, and her evaluation then consisted of a clinical interview only. The final evaluative decision of the psychologist: she was diagnosed with mood disorder due to medical condition and chemical sensitivity on axis 3. Axis 3, we used to have a 5-axis system in the DSM-4 and DSM-4-TR. It was actually very helpful. On axis 3, you would list any physical health problems that the person had. And then on axis 3, and then on axis 4, you would rate them as far as their level of functioning between 0 and 100. And anything down at 55 is quite poor. She was given a current level of functioning, general assessment of functioning of 55 out of 100. Our summary: the evaluator claims that the client had good mental status, social skills, and orientation, and that mood problems are due to a medical problem. Okay, patient E, a woman, she had been given medicine to cope with her severe asthma, and she believed that that medication had caused the onset of sensitivities. She has a lack of workplace accommodations. She has multiple medical problems, depression, hopelessness, previous suicide attempts before the appearance of MCS. She was seeing a psychologist because she was referred by her primary MD after a suicide attempt. And the psychologist discerned, quote, she clearly has an enduring pattern of impairment in areas of cognition, how she perceives and interprets herself, other people and events, affective reactivity, interpersonal functioning, and impulse control. And these impairments have caused significant social and occupational problems. She meets general diagnostic criteria for personality disorder. She has features of borderline, narcissistic, and paranoid categories, but does not clearly meet a specific personality disorder diagnosis. And she was given an assessment of 55 out of 100 for her life functioning. Our summary: the psychologist seems to reject the client's view that her illness was caused by a medication and looks for a psychological diagnosis. Although she does not meet any specific criteria for a mental disorder, the examiner has diagnosed her anyway. Patient F, a man, described as totally disabled. He had multiple diagnoses previous to this examination, which included both toxic-related and psychogenic causes. The reason for seeing a psychologist, he wanted a second opinion on whether it would be possible for him to work. He wanted to work. You hear so much myth about how people with disabilities don't want to work. They do want to work. The IME gave him a 35 out of 100 on his functioning, which is extremely low. And in his decision about the client, he said, "This gentleman is terribly dysfunctional, regardless of whether there can be a provable medical diagnosis involving immune deregulation and chemical and electrical sensitivity." Excuse me. He's preoccupied and obsessed with every aspect of his environment and is totally dysfunctional, totally disabled, and there is no possibility that he could be rehabilitated. Axis 1, delusional disorder and undifferentiated somatoform disorder. Axis 3, prior diagnosis of chemical and electrical sensitivity and immune dysfunction. Our summary, although the evaluator said that the client showed no evidence of thought disorder during the interview, he was diagnosed with both delusional and somatoform disorder. So one more, patient G, a woman, had workplace-related toxic exposures. Her history and her experience was she was having severe eye irritation, symptoms of depression and anxiety, and unemployment. She was seeing a psychologist for a disability determination. The final evaluative decision of the psychologist, and I saved the best one for last here, the practitioner concluded that, quote, "The history and presentation are consistent with multiple chemical sensitivity syndrome, and in my opinion, there is no evidence of a primary psychiatric disorder. In my opinion, the recent mild symptoms of depression and anxiety are expressions of the normal range of emotions from the stressors of the devastating medical condition and her inability to work." Our summary, the examiner believes the patient's suffering to be purely biologically caused and diagnoses her with MCS. So, in summary, 5 of 7 patients were acknowledged to have some environmental component to their illness, but in only 1 in 7 situations was the MCS seen as the primary or solitary problem. In several cases, people were expected to just deal with their health problems without any emotional reactions. And if they didn't or couldn't, then they were given a comorbid psychological diagnosis. Others were diagnosed with somatization, delusional disorder, mixed personality disorder, or poor defenses. In one case, the person was determined to be completely mentally ill, and in one, the person was seen as disabled by MCS. So we have a long way to go. It wasn't until like 30 to 40 years ago that psychology even acknowledged that people with accepted and understood illnesses such as diabetes, cancer, etc., had emotional reactions to them. We are nowhere near applying even what we know about that to invisible disabilities and invisible illnesses. People with MCS, electrical sensitivity, fibromyalgia, chronic fatigue are still being psychologized after all of these years. These are no longer emerging illnesses in my mind. I've been studying MCS since 1992. My students still don't know what it is. This is completely unacceptable. We need to apply what we know about adapting to a disability or an illness to illnesses we don't understand. We need to start understanding them. Okay, here are some resources. You can see my research website at mcsresearch.net. You can read my book for free or download it at this same site or at earthrivebooks.com. And you can see my other YouTube videos at my YouTube channel. Thank you so much for listening.